Good evening, everyone. How are you all? Okay, so let's start our tonight's session. And I hope you had a good break in between. We are going to finish pediatrics tonight. That's the deal. Okay. So there is still a lot of things that we have to finish tonight. So far we have finished few of the topics that is very important for pediatrics. We finished up to respiratory system last time. Now we are going to start with GIT. So pediatric GIT, mainly we follow Kaplan step to secant. So let's start. Okay, so I'll be a little bit quick today because we have got a lot of things to finish. And this is the last pediatric class, followed by you are going to have a pediatrics question solve class, right? So let's do how much we can do. So first topic for today is esophageal atresia and tracheoesophageal fistula. So this is one of the common congenital anomalies, in which case what happens is that sometimes the esophagus might not be fully formed. So if you look over here, this is the normal anatomy of esophagus and trachea. So just in front of the trachea, you have got the esophagus, and esophagus gets connected with the stomach. In esophageal atresia, so like this one, what happens is that the upper end of the esophagus ends in a blind pouch. And see this middle part, there is nothing there. So that's called esophageal atresia without any fistula. Now there is another condition where you get esophageal atresia with fistula, where esophagus ends in a blind pouch and the distal end of the esophagus gets connected with the trachea. Okay? So, and that is the commonest one in terms of esophageal atresia or esophageal anomalies. Okay? So you have got just atresia where there is no fistula, and then you have got atresia with fistula. So this is the main two subtype of this anomaly. Sometimes this condition can be associated with a condition called vectral. You don't need to know what is vectral, just remember the name. So vectral includes a lot of other organ anomalies. This kind of condition is not uncommon in Down syndrome child. So Down syndrome is one of the risk factor of having this kind of complication. So how usually children will present? So newborn baby, whenever the mother is trying to breastfeed, baby is vomiting it out. So if the breast milk coming out immediately after feeding and in the first 24 hours after birth, then you would be thinking of esophageal atresia. So esophageal atresia, the main symptom is vomiting after feeding. If there is a fistula, that means if the esophagus gets connected, so if the esophagus gets connected with trachea, what can happen is that sometimes food can go from the esophagus into the trachea, and it can cause aspiration pneumonia. And in those situations, children will get cough, cyanosis, respiratory distress, and sometimes even frothing, bubbling coming out of the mouth. Okay? So if it is just atresia, that means children will mainly have like vomiting of milk, no other symptoms. Whereas if it is atresia with fistula, they will have respiratory symptoms. How to diagnose this condition? So first of all, because the child is vomiting everything out, you need to put a NG tube to provide something for the child, right? So if you even need to give some nutrition, you need to insert a NG tube. But what will happen that because the esophagus is ending in a blind pouch, you will not be able to insert the NG tube, because NG tube will not be able to go past that. Okay, so inability to pass the NG tube is one of the most important clue to this diagnosis. And then you do a X-ray. So if you do the X-ray of this condition, you will get like this. So you can see the coiling of the NG tube. So see the coiling. So this coiling of the NG tube is a very important finding to diagnose esophageal atresia. How to differentiate atresia, like only atresia, with atresia plus fistula? So X-ray will be able to differentiate between these two. In case of atresia, X-ray will show the coiling of the NG tube with no distal gas, so gasless abdomen. Okay, so in case of just atresia, so if it is just atresia, there is no fistula, right? So if there is no fistula, there will be no air which can come through the trachea into the stomach. So that's why if you do a X-ray in just atresia children, like this child, there will be no gas in the abdomen. But when there is a fistula, air can go through the fistula into the stomach, and you can get this gas shadow in the abdomen. Okay, so if there is gas shadow in the abdomen with coiling of the NG tube, that means there is a fistula. And if it is only coiling of the tube but no gas, that means it is only esophageal atresia. So that's how we differentiate this thing. And the treatment is basically repair. So surgical repair is the treatment. Okay. So that was about your esophageal atresia and esophageal atresia with fistula. Moving on to next, gastroesophageal reflux. So there is two conditions that we use in children who suffer from gastro. So one is gastroesophageal reflux and another is gastroesophageal reflux disease. So these are not same. Gastroesophageal reflux is a physiological process which can happen in any children less than 12 months. So children less than 12 months, their lower end of the esophagus is very immature. So sometimes what happens, if you put them down after having a milk, because the sphincter is not that much strong, the breast milk can come out of the mouth, especially if you immediately put them to bed after having a milk. Okay, so that's very common symptoms of gastroesophageal reflux. So if the patient says or parent says that the child vomits or maybe just a bit of spitting out of the breast milk, okay, but apart from this spitting out, there is no other abnormality, which means that the child will be gaining weight appropriately. Child will attain all the developmental milestone. So everything else will be fine, except only there will be a bit of vomiting, and the vomiting will be whitish. That means the breast milk. So only the breast milk will come out, usually after having a milk. Okay, so that's the main symptom. So gastroesophageal reflux is regurgitation of food because of reflux is a common physiological event in newborn. Milk will flow freely from the mouth soon after feeding. Sometimes it can be forceful, but that doesn't mean anything. Despite the vomiting or regurgitation, the babies are usually comfortable and thrive. Sometimes this can cause a little bit of irritable baby, and child can cry because of the heartburn. But in a small number of children, the reflux can become severe enough to cause serious problems, such as esophagitis, anemia, stricture, failure to thrive, etc. And when it does, it's called gastroesophageal reflux disease. So reflux disease is the pathological form. When we call it reflux disease, there is a criteria that you need to fulfill. So if you go to RCH guideline about it, you will find it out. So read this thing by yourself. So you consider gastroesophageal reflux disease if a child having a reflux like vomiting, along with that child is refusing to feed, pronounced irritability with feeding, aspiration, chronic cough, wheezing, slow weight gain, and hematemesis. So if a child with just reflux start to like having a little bit of slow weight gain, child is not like accepting the milk or refusing to feed, pronounced irritability, if any of these are there, that becomes a gastroesophageal reflux disease. Remember, both gastroesophageal reflux and the disease can be diagnosed by just history and examination. There is no need of any investigation. How will you manage this condition? So for reflux, there is usually no treatment needed. So simple gastroesophageal reflux require reassurance and some kind of general measures, which means that you will advise the parents to keep the head elevated after they put the child in the cot. They can also use some food thickener. So sometimes this is actually what comes in exam. So you can give them some Gaviscon. So if it is really troubling the child and child is vomiting a lot, then what you can do is that apart from breast milk, some of the breast milk you can express, and then you can mix it with some food thickener such as Gaviscon, and then you can give it to the baby. Okay, and in that way, because if it is thick, it will have difficulty to come out of the mouth. Okay, so food thickener is usually the one that comes in exam. And other than that, small frequent meals, those are the things that can be tried. Now have a look on this flow chart. A child who you think that might have gastroesophageal reflux, in those situations, the only thing that you do, so if it is just reflux, all you need to do is to just do simple measures. So parental reassurance, support, education, that's all that you need to do. But if the child having symptoms of reflux disease, in that case, you will refer the child to a pediatrician, and pediatrician can do few steps. First of all, pediatrician will try to rule out cow's milk protein allergy. So the pediatrician will give a 2-week trial of cow's milk exclusion. Even after that, if the symptom is still unchanged, then pediatrician can give a 4 weeks trial of omeprazole. Okay, so that's usually the treatment of choice. That doesn't come in exam, but you should know. So for just reflux, the treatment is simple management, nothing else. Food thickeners, elevating the head of the bed, and a small frequent feeding. Okay. No need of any investigation, but sometimes if the child is developing reflux disease and child having persistent symptom, then pediatrician can order investigation to confirm the diagnosis, such as esophageal pH monitoring, endoscopy, and biopsy. Okay, so that's usually what you are going to do in this patient. So it's not what we do. The pediatrician can do this investigation, such as esophageal pH monitoring, or even sometimes endoscopy biopsy. Okay, so that's usually the management for gastroesophageal reflux and gastroesophageal reflux disease. Any question, guys? Good. Moving on to pyloric stenosis. Pyloric stenosis is very important for exam. So it's common in between 2 to 4 weeks old or 2 to 6 weeks old. So children who develops pyloric stenosis, the main problem is that, so this is the esophagus, and then you have got the stomach, and the end of the stomach is what we call as pylorus. So children who has got pyloric stenosis, this pylorus is quite narrowed. So food cannot go from the stomach into the duodenum. So whatever child is taking, it's going out by vomiting. So children in this condition will get non-bilious projectile vomiting. That's the main complaint. It's common in firstborn males. Main presentation is non-bilious projectile vomiting. And because the child usually vomits after feeding, so they are hungry. So even after feeding, they feel like they're very hungry and cries immediately after feeding. So if a child is having a non-bilious vomiting, which is forceful and projectile, and most importantly, if the child is not gaining enough weight. So the main criteria to diagnose pyloric stenosis is that the non-bilious projectile vomiting with child is not gaining weight. Okay? And if you do examination, sometimes, not always, you can get an olive-shaped mass on the epigastric region. And sometimes you might be able to notice a peristaltic wave coming from the left upper quadrant of the abdomen going to the right lower quadrant. Okay, so just remember, you can get a olive-shaped mass and a peristaltic wave in this case. It's not always, but if you get the olive-shaped mass, then you can diagnose pyloric stenosis even without an ultrasound. But if you don't have this finding, then you will need to do an ultrasound to confirm the diagnosis. So the way of confirming the diagnosis is abdominal ultrasound. Because child vomits everything out, when you vomit, you lose acid, right? So children who develops this condition, they develop alkalosis because they are losing all the acid. So metabolic alkalosis is one of the important finding in this child. And because with vomiting, they are losing potassium and sodium, these children also get hyponatremia, hypochloremia, and hypokalemia. And they also can get quite dehydrated. Okay? So that's usually the finding of pyloric stenosis. Go to the RCH for this one as well. It's important. So these are the risk factor, male, firstborn, preterm. So all of these you can go through. And the vomiting is recurrent and progressively forceful projectile. May occur shortly after feeding. Infant appear hungry even after feeding. Non-bilious. And weight loss is one of the other findings. When you examine, you can look for dehydration, visible peristalsis, and a olive-shaped pyloric mass. Investigation. So for this patient, because this acid-base imbalance is very prominent in these children, so you will have to do a blood gas analysis, and you will also need to check their electrolyte. So that's your initial investigation. And then if the question asks how to confirm the diagnosis or how will you investigate this patient, that will be abdominal ultrasound. Okay? And sometimes question asks that what is the acid-base imbalance that you can get in this child? So that's hypochloremic, hypokalemic, metabolic alkalosis. Treatment. The first line treatment is stabilize the child. So IV fluid, stop feeding and put a NG tube if the child is having a continuous vomiting. But the main thing is IV fluid and correction of dehydration and electrolyte imbalance. Once the child is stable, then the treatment will be surgery. Okay, so repair of this stenosis is the main treatment. Okay, so that's about this pyloric stenosis. Gastroesophageal reflux, just reflux? No, we don't need to refer to pediatrician for that. If it is reflux disease, then you can. Next, duodenal atresia. So far we have done up to pylorus. Now the problem is in the duodenum. So sometimes the children can have absence or improper development of duodenum, jejunum, or ileum. right? So all of you know the basic anatomy, right? So if this is the stomach, then you have got the duodenum, then the jejunum and ileum, and the ileum will get connected with the large bowel, right? So if there is atresia of the duodenum, that's duodenal atresia, and also the child can have jejunal or ileal atresia. So most of the time, duodenal atresia is common in premature baby and Down syndrome babies. The main presentation is bilious vomiting. So this is the time you start to get this kind of greenish vomiting. So bilious vomiting without any abdominal distension on the first day of life. So that's the main feature. So if the child gets bilious vomiting without any abdominal distension, there will not be abdominal distension because everything is coming out, right? And it will be on the first day of life. If you do the X-ray in these children, that's the way to confirm the diagnosis. You will get a classic double bubble sign. So this is how it looks like. So if you look over here, you can see. So this is called sign that we can get in a duodenal atresia child. You would never get this kind of double bubble anywhere except duodenal atresia. Okay? So if you get double bubble sign and the child having bilious vomiting on the first day of life, that's duodenal atresia. Treatment, first of all, just IV fluid, NG tube, and the main treatment is surgery. What about jejunal and ileal atresia? These also occur on the first day of life. They also give you bile-stained vomiting or bilious vomiting, but these children will have abdominal distension. Because once the food passes the duodenum and then it can't pass anymore, that will give some distension. Okay? So jejunum and ileal atresia, the children will have everything similar to duodenal atresia, except these two will have abdominal distension. And if you do an X-ray, you will not get double bubble sign, rather you will get multiple air fluid level and dilated loop of bowel. This doesn't come in exam because it is quite difficult for anyone to diagnose jejunal or ileal atresia. So don't bother with that. The only thing that you need to know how to differentiate between these two. Okay? Next. Very important question is intussusception. So what is intussusception? So intussusception is a condition in which one bowel, so this is one bowel, it's called telescoping. So one bowel get entered into the another bowel. So telescoping of one bowel into another is what we call as intussusception. Now, because it is quite tight over there, the blood supply on this part of the bowel can get cut off. And children can have like extremely severe pain. So they will have episodes of severe pain. And during that painful time, they will scream. And also they can bring their knee to the chest and they can clench their fist as if they're in severe pain. Okay, so painful screaming episodes, and children is like bringing their leg up to the chest and also clenching their fist to show that they're in a lot of pain. That's the time we consider intussusception. So sudden onset of severe paroxysmal colicky abdominal pain. Apart from that, children also can get a greenish vomiting in here. So bile-stained vomiting can be there. And sometimes, not always, children can give a black, currant, jelly-like stool. So if there is mucosal necrosis happens, so because of cutting of the blood supply, the mucosa can start to have necrosis. If necrosis happens, then this kind of like classic black currant jelly-like stool can come out. Okay. So that's how intussusception mainly presents. So it is common between 3 months to 6-year children. Sometimes can follow an upper respiratory tract infection by adenovirus or rotavirus. Can be associated with a condition called Hennoscholin purpura. Okay. So if you do a physical examination, what will you find? You can find a sausage-shaped mass in the abdomen. So that's one of the findings that you can look for. How to confirm the diagnosis, or what will you do to diagnose this condition? Your first test can be an ultrasound. And ultrasound usually will be able to confirm the diagnosis. What is the treatment? Treatment of choice is air enema. Okay, so air enema means that you will insert a tube into the anal area, and through the tube you will pass air. And sometimes if you can pass a forceful air, this telescoping of the bowel can get unobstructed. And that's usually the treatment of choice. And if it helps, it also confirms your diagnosis. So it is both diagnostic and therapeutic. If air enema is unsuccessful, then you go for surgical repair. Okay, so that's the treatment. Now, RCH has got a good discussion about intussusception. Let's have a look. So the triad of intermittent abdominal pain, palpable abdominal mass, and a red currant jelly stool occur only 1/3 of patients. So not always you get everything. Children, usually 2 months to 2 years, most of the time it is idiopathic. And this is the main feature that you can get, which we discussed already. On examination, you can get this sausage-shaped mass, abdominal distension, sometimes even tenderness, guarding. This can be there. Management: IV fluid, analgesics if the child is in pain, and then most of the time you will first do an ultrasound and then start with air enema. So ultrasound is the treatment. If you suspect perforation of the bowel, then you will have to do an abdominal X-ray, and air enema is the main treatment. Okay. So air enema is just like inserting a tube through the back passes, and then through that tube you just pass a forceful air, and with that air sometimes the bowel can get unobstructed. Okay. Yes, there are lots of RCH guidelines, Dr. Shabab. The important ones usually I ask you to go through. So only the ones that we are discussing, you should go through them. There is a condition called Hirschsprung disease. So Hirschsprung disease is not very important, but just remember one thing, that it's a condition which usually presents at birth, and we should suspect about this if it is a full-term infant with a delayed passage of meconium. So ideally, meconium should be passed within 24 hours after birth. If there is delay in the passage of meconium after 24 hours, and child having features of bowel obstruction, so abdominal distension, like there is no gas or no stool coming out, child is vomiting, okay, in that case it is features of bowel obstruction. So delayed passage of meconium with features of bowel obstruction, you can think of Hirschsprung disease. So what is Hirschsprung? It's a condition where the nervous cell in the gut is absent. So you need the nerve, or you need the ganglion cell for the peristalsis. If there is lack, or if there is absence of this ganglion cell in the intestinal wall, there will be no peristalsis. So the meconium or anything the child is having, it cannot push forward, and then obviously there will be constipation followed by bowel obstruction. So that's Hirschsprung disease. Diagnosis: you can start with a rectal manometry, but the confirmatory is rectal suction biopsy, and treatment is surgery. Okay. Just remember the important points, not too much. There is a discussion in RCH about constipation in children. I want you guys to go through that. At least just remember what are the first line medication, second line medication for constipation. Okay, so read it by yourself, please. Moving on to urinary tract infection. That brings us to finishing off GIT. Any questions so far? Okay. Moving on to urinary tract infection. So there is also a good guideline in RCH about UTI in children. You will need to go through that. Apart from that, let's discuss few things from John Mutter. So what is UTI? All of you know what is urinary tract infection. So children presents in a different way than adult. Many children can't say that they're having burning discomfort during passing urine. So especially infant, they present with fever, vomiting, maybe sometimes even like lack of eating, and sometimes they can also cry during passing the urine. So if a child is crying while passing urine and having a fever, you would think of a likelihood of UTI. Sometimes also parents say that their urine smell very funny. So funny smell from the urine, child having a bit of fever, maybe crying during passing urine, then you would think of UTI. Okay. If it is a little bit older children, they can say that they are having burning discomfort, increased frequency of urination. So they can say the symptoms in that case. So all children who you suspect to have a UTI needs investigation. So the first test that we do if we suspect it is just start with a urine dipstick if we can. And if the urine dipstick shows that there is a likelihood of urinary tract infection, then we send it to the lab to look for the organism. That's usually what we do in an adult patient. But for children, not everyone can give you urine when you request it. Like if you ask a 1-year-old to give urine, will they be able to give it to you? No. So there are age limitation to collect urine sample to even send it to the lab. So how we do it? So in children less than 12 months, the most reliable way to collect urine sample is suprapubic aspiration. Okay? And that is the only way. So only way or the best way to collect urine from less than 12 months. Between 1 to 4-year-old, during this time, you can try a clean catch urine sample. So what will happen? The children will like whenever child is going for a pee, the parents will try to catch the urine while child is urinating. So that's called clean catch urine. If it is possible, then yes, we can do that. And when a child is more than 4-year-old, that's the time the child usually can void or can have urination on request. And that's the time we go for midstream urinary specimen. Okay. So less than 12 months, suprapubic aspiration, 1 to 4-year, clean catch urine, and more than 4-year, midstream urine. Okay. So remember that. So UTI in infant and very young children is often kidney in nature. So sometimes UTI in children might not be just the lower urinary tract. It can involve the kidney, which can present as fever, vomiting, even diarrhea, and failure to thrive. Offensive urine may be noted. Symptoms of dysuria and frequency appear only after the age of 2 years. Now, what is the guideline of investigation? So first of all, we say that any child less than 1 year, if they get a UTI, especially if they get recurrent UTI, so more than one, that child needs further investigation to know if there is any other abnormality going on in their urinary tract. Okay, so if a child having recurrent UTI, you will need to do an ultrasound. And if ultrasound shows anything abnormal, then we do micturating cystourethrogram or voiding cystourethrogram. So we call it MCUG or VCUG. So micturating cystourethrogram or voiding cystourethrogram, where you put a dye and the dye goes through the whole urinary tract to look for any abnormality. Okay, so why we do it? There is reason for it, because many child who develops recurrent UTI, they can have underlying anomaly in their urinary tract. One of the common one is vesico-ureteric reflux. So what happens is that, I don't have a picture in here, but let me discuss. So if this is the kidney, and that's the ureter, and that's the bladder, right? There is a valve here which prevent backflow of the urine from bladder to the ureter. There should not be any backflow. But if this valve is not working, then there might be a backflow of urine from bladder into the ureter. So ureter will start to become dilated. And at some point, the kidney will start to have fluid or dilation, which we call hydronephrosis. And at some point, if there is a lot of urine backflowing, the kidney will start to become smaller. And that is what we call as a scarring of kidney. So a scarred kidney. So to diagnose this condition, you need to do an ultrasound. And sometimes ultrasound can be able to give some idea that it could be some abnormality. And then to confirm it, you do a MCUG. If MCUG shows that, like if ultrasound and MCUG shows likelihood of a scarred kidney, to confirm the scarred kidney, you have to do this scan called DMSA. Okay, so that's the step-by-step of investigation for a recurrent UTI in a child. So ultrasound, MCUG, and then DMSA. Okay. It's not only just less than 1 year. So any child having recurrent UTI, you would be doing these investigations. And most importantly, if it is less than 1 year old, then even first time UTI, sometimes we do ultrasound. But for more than 1 year old, you can wait for at least more than one. Okay. So guidelines for investigations are, if it is less than 1 year old, even with first time UTI, sometimes we consider doing an ultrasound just to look for any other abnormality. But for more than 1 year old, usually more than one episode of UTI will be regarded as recurrent UTI. And for them, you would do ultrasound. Now, first investigation is ultrasound. Once ultrasound is done, and if it shows anything abnormal, you do a dye test, which is called micturating cystourethrogram or voiding cystourethrogram, which is VCUG. Same thing, just the name is different. And this dye will be able to look for any anomalies, such as vesico-ureteric reflux. Sometimes, if a child has got VUR, like vesico-ureteric reflux, which is backflow of urine from bladder to kidney, they can get a small kidney or a scarring of kidney. So to rule out a scarring of kidney, we do this DMSA. Okay, so there's a step-by-step approach. Now, treatment. Once you diagnose that this child has got UTI, the treatment is any of them. So you can give them oral trimethoprim, cefalexin, cotrimoxazole, or amoxiclav. For children, we don't give norfloxacin or ciprofloxacin. Less than 1 month old, any less than 1 month old having possible UTI will be going to the hospital for IV antibiotic. But for more than 1 month, if a child doesn't look really unwell, then you can try oral antibiotic. What if child is having severe UTI? So for children who has got severe UTI, such as they are vomiting, dehydrated, looks quite unwell, for them you would go for IV antibiotic with IV gentamicin plus IV amoxicillin. Okay, so that's all about urinary tract infection in children. Next, glomerulonephritis. So all of you have some idea about glomerulonephritis, right? So glomerulonephritis means inflammation of the kidney, most importantly, inflammation of the glomerulus. The most important glomerulonephritis is IgA nephropathy and PSGN. Okay, so first of all, there might be nephritic syndrome, it could be nephrotic syndrome, or it could be asymptomatic kidney disease. So glomerulonephritis has been divided into these three. Nephritic syndrome, its main presentation is edema, hypertension, and hematuria. But the main among these three, the main is hematuria for nephritic. Whereas for nephrotic, the main feature is edema because of proteinuria. Okay, so when there is 3 plus 4 plus proteinuria in a child plus edema, you would think nephrotic syndrome. When there is 3 plus 4 plus hematuria in the dipstick plus edema, you would think of nephritic. So that's the easiest way to think, is it nephrotic or nephritic? Can a nephritic syndrome patient can have little bit of proteinuria? Yes. So nephritic also can have 1 plus 2 plus proteinuria. Vice versa, in nephrotic syndrome, they can also get 1 plus 2 plus hematuria. So a lot of candidate has this kind of idea that if there is hematuria, it is always nephritic. It's not like that. It's all about how much. So a child having 3 plus hematuria and 1 plus proteinuria, we would think more likely that it is nephritic. Okay, so it can be a combination of everything, but what's main? If main is hematuria, then we think a nephritic. If main is proteinuria, then we think nephrotic. Okay. Now, there are lots of causes of nephritic syndrome. The most common cause in Australia is IgA nephropathy. There is also post-streptococcal glomerulonephritis, which is PSGN. PSGN is not that common in Australia, only common in Aboriginal and Torres Strait Islander, which is indigenous population. Then it can be thin glomerular basement membrane disease and some other vasculitis. So IgA nephropathy is the commonest cause of nephritic syndrome in a child. So what is IgA nephropathy? So it's a hematuria in a young patient. Most of the time it is young adult. Sometimes it can be children. But the main presentation is hematuria. So hematuria at the time of or within 1 to 2 days of a mucosal infection. So the child has got a recent upper respiratory tract infection. During upper respiratory tract infection or within 1 to 2 days of this infection, if the child develops hematuria, you would think of IgA nephropathy. So what happens, that child has got a viral infection, your body will start to produce some antibody to fight against this infection. On that process, the body will produce IgA antibody, right? So that IgA antibody complex can get deposited on the glomerulus, and then it can cause inflammation of the glomerulus hematuria. That's usually the main way of doing it. But the prognosis is very good. There is no specific investigation that you can do to confirm this diagnosis. All you can do is, if you check the urine, you will get some hematuria, and the clinical symptom will give you the diagnosis. There is no specific treatment as well, but if the child start to lose a lot of protein in the urine, if the child having deteriorating kidney function, then you will need to refer the child to a kidney specialist for a possible immunosuppressive treatment, such as a steroid or even sometimes some stronger immunosuppressant. The only way to confirm it is by kidney biopsy, which we normally would not do just for diagnosing, because there will be no change in the treatment. Okay, so that's IgA nephropathy. Next, acute post-streptococcal glomerulonephritis, so PSGN. So all of you know about PSGN, or post-streptococcal glomerulonephritis. So this is common in children who are indigenous communities. So they get a group A streptococcal infection, and most importantly, group A streptococcal throat infection, or even sometimes impetigo, which is a skin infection. So following a throat infection or an impetigo, if a child develops hematuria, usually after a week, so IgA nephropathy within 1 to 2 days of an infection, whereas PSGN is within 1 to 2 weeks of an infection. So if they get hematuria and also they get edema, so sometimes the edema can start around the eye, so periorbital edema, and then it can involve the legs and everything. Scanty urinary output, so oliguria, and sometimes it can be complicated with hypertension. So usual course is first they develop oliguria and then edema and hypertension. But it's a very good prognosis, usually doesn't do any long-term complication. Okay, so the way of diagnosing it is a streptococcal throat infection. 1 to 2, usually within 1 to 2 weeks of that, child getting hematuria, oliguria, bit of edema, then you think of PSGN. How to diagnose this? You'll need to confirm that the child has got a streptococcal infection. So you can either do ASO titer, you can also do a antigen for group A streptococcal infection. But most of the time we do a ASO titer. If the child still has got sore throat, then you can do a throat swab. But most of the time it happens after a week of sore throat. So you might not even be able to get anything by a throat swab. So that's why ASO titer, anti-DNSB, or group A beta hemolytic streptococcus antigen will be the best idea. We also check C3, C4 in PSGN. So these are complement level. This complement level will be low in these children. Okay. Treatment is hospitalization, bed rest, strict fluid balance chart, because child is having like oliguria and edema. So fluid balance chart has to be maintained, and fluid restriction can be given because of fluid retention. Low protein, high carbohydrate and low salt diet is the treatment. So this comes in exam sometimes. So the treatment for nephritic syndrome is low protein, high carb, and low salt. Low salt because the child is having retention of fluid. So if you give more salt, there will be more retention. So low salt diet, high carb, and low protein is the treatment. If the child develops hypertension, then we can use some antihypertensive. The common antihypertensive that we use in a child is calcium channel blocker. Usually, we don't need to give any diuretics for these children unless they're having excessive swelling. So apart from this, you don't need to do anything for these children. Once the fluid retention is a bit better, then the child can go home. But usually you will need to monitor their blood pressure and kidney function for a long time. So regular urine analysis, checking the blood pressure and kidney function is needed. And as long as their kidney function is good, their blood pressure is good, nothing you need to do. Remember, children with this kind of PSGN can have a microscopic hematuria for years. It doesn't mean anything. All you will do is to reassure the parents. Nothing needed to be done for that. Okay? So that's post-streptococcal glomerulonephritis. Yes, so every PSGN will be admitted to the renal unit. Did not get the question, Dr. Mujahid. ASO titer positive how many days after sore throat? ASO titer can take, it's just a variable time. There is no specific time for it, but after a week you can do it. IgA nephropathy, there is no treatment. So you just like review the patient, review their kidney function, review the blood pressure and everything. As long as their kidney function is good, there is no specific treatment is needed. But if they start to have like deterioration of kidney function, losing excessive protein, then you can start some immunosuppressant, which is a steroid. Okay, but that will be done by a kidney specialist. We can use diuretics for edema, but it's not usually commonly that we use. Yes, I already answered that, Dr. Pravina. We need to admit the PSGN just initially, because this strict fluid balance chart cannot be done at home. Okay, so it initially the child needs to be admitted. Child needs to have this fluid restriction and everything, and then once it is a little bit better, you can discharge them. Okay, we'll take a 10-minute break now, and then after the break, we'll start with nephrotic syndrome. And for the UTI investigation, Dr. Amima, we already discussed quite a few times now. So maybe just go through the recordings after the class. Okay, it is a bit complex, but if you go to the recordings after the class, it should be okay. No need of antibiotic for PSGN. No, we don't give antibiotic for PSGN. Pyloric stenosis is not a congenital anomaly. So it's not like that the children will born with pyloric stenosis. That's why it doesn't happen in the first day of life. And IgA nephropathy from PSGN, as I said that IgA nephropathy, it takes usually hematuria presents within 1 to 2 days of the infection. And PSGN, hematuria happens within 1 to 2 weeks of the infection. Okay. All right. So we'll take a 10-minute break now. Thanks, everyone. All right, everyone, let's start again. Any questions so far? Okay, so moving on to nephrotic syndrome. So nephrotic syndrome, as I say, that it is also one of the commonest cause of having edema in a child. Main pathophysiology for nephrotic is proteinuria. So children will lose excessive protein through the urine. And one of the main part of protein is albumin. So if they're losing a lot of albumin through the urine, they will develop low albumin in the blood. So hypoalbuminemia. And albumin is a very important part of like fluid balance in the body. So when there is low albumin, fluid will start to shift in the interstitial space, and that will cause the edema. So children can get generalized edema. Even though there is fluid accumulation in these children, but the fluid is going to the interstitial space. But the children can get dehydrated because in the intravascular area, there is lack of fluid because of fluid shifting. So even though child looks having a lot of fluid, still this kind of children can be quite dehydrated. Okay. So nephrotic syndrome can occur at any age, but it's common in children like above 3 to 4. Main feature is proteinuria more than 3 gram per day, generalized edema, hypoalbuminemia, hypercholesterolemia, and in this case, children gets normal blood pressure and sometimes a frothy urine. Okay, so the commonest cause of having nephrotic syndrome is minimal change disease. Other than that, it could be idiopathic, could be focal glomerular sclerosis, membranous nephropathy, etc. And sometimes it can be due to diabetes, SLE, amyloidosis. Sometimes even malaria can cause it. So how to confirm the diagnosis? The first test is urine test. So in the urine dipstick, you will get 4 plus 3 plus proteinuria. And after that, you will do some blood test. In the blood test, you will get hypoalbuminemia, high cholesterol. And if you will be also rule out nephritic syndrome. So you will be doing ASO titer, complement, all of them will be normal. So once you diagnose them, then the treatment. This patient also needs to be admitted to the hospital in the renal unit, bed rest, strict fluid balance chart. So low fluid, high protein, because the child is losing protein, so you'll have to give more protein, and low salt. The main medication for this patient is prednisolone. So most of the nephrotic syndrome children, they are quite sensitive to prednisolone. So usually prednisolone is the one that should be able to treat the condition. And for fluid, you can give them diuretics, and many times, like especially sometimes this kind of patient are more prone to develop clot. So septic thrombophlebitis, then they can also get renal vein thrombosis. So that's why sometimes we put them on aspirin to minimize the risk of clot. But if a child who has got nephrotic syndrome complaining of abdominal pain, few things you should consider. One, if nephrotic syndrome children having abdominal pain with abdominal tenderness plus fever, then you will be thinking of spontaneous bacterial peritonitis because they are very prone to get infected. And a nephrotic syndrome child having flank pain but no fever, nothing else, then it could be a renal vein thrombosis. Okay, so these are important complications. RCH has got a very good discussion about nephrotic. I would like you guys to go through the RCH guideline, okay, in detail about the nephrotic. Okay, so that's mainly all the kidney related condition that you will need to remember from pediatrics. Any questions from the renal unit, guys? Moving on to a very complicated as well as something which will haunt you a lot is developmental milestone. If any of you read it, you know you don't like it, and you will never be. But unfortunately, you will need to memorize it. So, developmental milestone, it comes in exam in a lot of ways, but there is no way that anyone can help you to memorize it. It's something that you need to memorize it every day. Okay, so children throughout their birth, and then when they become like more and more younger child, they develop milestone. They attain new things, and you need to know which age they are supposed to get what kind of milestone. Okay, and if they don't attain it, that means it is abnormal, and that's red flag. Okay. So some of your question, what did you say after SBP? Renal vein thrombosis. So if a child with nephrotic has got a flank or loin pain, that means kidney pain, we can think of renal vein thrombosis. And dietary management in nephrotic, so high protein, low salt, low fluid. So coming back to developmental milestone, there are 4 milestones that every child usually should have. So gross motor, which means basically walking. Visual motor, so using the fine things, that means using a pen, using the thumb. So fine motor or visual motor, language, and social skill. So a 2-month-old child supposed to at least raise the head. So 2-month-old should be able to raise their head in prone position, and then they start to smile in response to touch and voice. And by 2 months, they are able to recognize their parent. 4-month-old, they hold their head steadily and they can roll from prone to supine position. And 4-month-old can also reach with both arms together. They laugh, they orient to voice, and they start to look around. None of these are very important for exam. 6 month is very important. 6-month child start to sit with support. Okay, so sitting with support is 6 months, that's important. And they can start to transfer object, especially with one hand. Okay, so they can reach towards an object using one hand, so unilateral reach. And sometimes they can start to transfer object from one hand to another. And 6-month-old start to have like unrecognizable or incomprehensive sound, which is bubbling. So bubbling start at 6 months. And they also know if someone is a stranger. So a stranger anxiety starts at 6 months. So these are important. 7 months, not important. 9 months, child starts to crawl. And sometimes they can start to hold the bottle. They can throw object. And they can start to say mama, dada. Not quite well, but they can start it. They understand no, so that's important. In which age they understand no? At 9 months. 12 months is very important. So they can start to walk. So children by 9 months to 12 months, they start to gradually stand with support. And between 12 to 18 months, they will start to walk. Every child must walk by 18 months. Okay? If not, that's a red flag. And they start to have the mature pincher grasp. Pincher grasp means they can hold something using the thumb and index finger. They can also say 1 or 2 more words rather other than mama, dada. So that's important. And they can imitate action. They can come when you call them. Okay. 18 months, very important. They start to run. They can scribble spontaneously, and they can build a tower of 3 blocks. They know their body part, so that's important. And they start to play in company with other children. So group play. Okay, so 18 months runs, scribble tower of 3 blocks. 24 months is super important. They can start to walk up and down stairs one at a time. Okay, so walking up and down stairs. Then you have got visual motor. Visual motor, they can build tower of 7 blocks. They can remove their clothing. They know 50 words by the time, and this one comes in exam. So they can have 2-word sentence. So 2 year, 2-word sentence. And follow 2-step command. 3 year can go up and down stairs using alternate foot. So alternate feet going up the stairs, and they can start using a tricycle. That comes in exam. They can copy a circle, and they can undress completely. This comes in exam, 3-word sentence, and knows all plurals. Sorry, knows all pronouns. So when a child knows all pronouns, 3 years. 3-word sentence, 3 years. And they also knows their full name, age, and gender. They do the group play, share, and take turns. 4-year-old, they start hopping and skipping, comes in exam. They can dress completely and copy a square. They knows color. They ask a lot of questions. So all the things that I have pointed out, you should remember it. But the ones that I have given a star, these are mostly the most important ones. So you have to memorize these ones. But other than that, the ones that I have just touched like this, you can also read them. So 2-step command means that you ask the child like, can you fold that paper and then put it on the table? So 2-step command. First fold the paper and then put it on the table. Okay? Any question, guys? So I know there is no question in here, but you will have to memorize these things. Okay? So this one is from Kaplan Step to CK. And this one is from John Murtagh. So John Murtagh hasn't given a really a good ones, but you can go through it in your own time. That's fine. So they have also given some other things, like you can see the whole hand activities. So 3 to 6 months, child starts to have grasping object. 6 to 9 months, banging the objects together. By 9 months, babies should be doing hand-to-hand transfer. In terms of speaking, between 3 to 6 months, child start this bubbling, and then between 6 to 9 months, bubble start to become bit of mama dada, and from 9 to 12 months, child starts to have mama dada constantly, and then by 12 months, 1 to 2 more words. Around 6 months, separation anxiety starts, and around 7 to 9 months, they have a stranger anxiety. Okay. Now there is a guideline in here which shows all the red flags, and that is very, very important to know. It's not here. Okay. This one. So among all these things, you need to know few red flags, which is super important for exam. So let's see. If a child did not have any clear word by 18 months, that's a red flag. According to RCH, if a child not able to walk independently by 2 years, that's a red flag. And by 18 months, child is supposed to stand independently. And they're supposed to walk without support, or at least attempting to walk. Okay? These two is the most important two. So no clear word by 18 months and not able to walk independently by 2 years. So please remember it. Okay, so that's finishes the developmental milestones. If you can memorize what we have discussed, that should be enough. Okay. Any question with the milestones? JM is not enough all the time, so sometimes we read Kaplan as well as we're doing. So we normally do discuss both. Okay, Dr. Ayman? Okay, so moving on to some specific problem of children. So this is from John Murtag. So these are not super important, but time to time there will be some important topics that will come. So blocked nasolacrimal duct, not super important. You can read by yourself. Growth velocity. So this is important for exam. So growth velocity, it helps us to know that if a child is growing appropriately or not. So what is this growth velocity? So sometimes children can be brought by their parents because they're having short stature or very tall stature or delayed puberty. So when there is abnormal growth and development, growth velocity can help us to have an idea that where exactly is the problem. To check the growth velocity, we need the bone age and chronological age. So chronological age means like a 13-year-old boy coming with the parents because of delayed puberty. Okay, so 13 year is chronological age. And then you do a X-ray of the wrist to find out the bone age. Normally, bone age should be equal to chronological age. So normal, that's ideal. But even if the child has a genetically short stature, like a familial short stature, then bone age will be equal to chronological age. And there is nothing you can do about it because it's a genetic pattern. Okay, so there will be short stature, and that is how the child or how the boy is built. But sometimes, even in some chromosomal abnormalities or some other genetic abnormalities, You can get a bone age equal to chronological age, but some abnormal physical examination finding. Now, this is not needed. It's very unusual to get this. So forget about it. Just remember that in a genetically short stature children, the growth velocity will be as bone age equal to chronological age. That's it. How about if a child has got bone age less than chronological age? Like this 13-year-old, the bone age coming as 10 years. Then two conditions can be. So if all the physical examination is normal, that can be constitutional delay. If there is some abnormal physical exam, then it could be related to some other chronic disease or hormone related issue. Again, that's not important for exam, but constitutional delay is important. We will come into that. What if bone age more than chronological age? That can be found in familial tall stature, can be found in precocious puberty, congenital adrenal hyperplasia, or hyperthyroidism. Okay, so bone age equal to chronological age. If it is normal physical exam, maybe just a familial tall stature, or if there is some abnormal finding, then it could be any of those. Okay? Now, let's have a look. A child, 13-year-old, brought by father because father think that son is short. Otherwise, child is healthy. He is below the 5th percentile for height and has been all of his life. So that means all of his life he is a bit short. Father is 6'3", mother is 5'10". Father was a late bloomer. So that is what you get in a constitutional delay child. So in constitutional delay, child is short prior to onset of delayed adolescent growth spurt. Now, what does it mean is that everyone has a different way of gaining puberty. Some gets early puberty, some gets a bit of delayed puberty. But as long as they are gaining their growth spurt at some point of their puberty, it's fine. So there are children who are late bloomer, means that they at the end they gain the actual weight, actual height, but initially they have a bit of delayed puberty or delayed growth spurt. So child will be short prior to this growth spurt. Their parents will be normal height, and at the end the child will attain the final adult height, which will be normal. The only thing that is delayed is the growth spurt and puberty. And in this patient, their bone age will be also delayed in comparison to the chronological age. Okay, so that's called constitutional delay. So that means child, apart from short stature, child is completely fine. There is no familial short stature. So everything is okay. And at some point, child will gain the growth spurt. The way to differentiate between familial short stature and the constitutional delay is constitutional delay will have bone age less than chronological age, whereas familial short stature will have bone age equal to chronological age. Okay? Making sense, guys? Very good. And then there are some pathological short stature, which means that it can be craniopharyngioma, hypothyroidism, hypopituitarism, chronic medical conditions. So any of these can cause pathological short stature. So how can we know by X-ray? It's not your job. So radiologist will be able to say what's the bone age. Delayed puberty. So delayed puberty is the absence of pubertal development either in boys or girls. So if a boy does not get the puberty by 14, and if the girl does not get the puberty by 13, that's called delayed puberty. The common cause of delayed puberty is constitutional delay and familial condition, but most importantly, constitutional delay. Chronic medical condition, poor nutrition, eating disorder, any of these can be a cause as well. If there is a feature that it suggests delayed puberty, then you'll need to refer the child to a pediatric endocrinologist for further investigation. And you can also start with checking the testosterone level for the boys and estrogen level for girls. Okay, so you can do this. So you can check the testosterone and estrogen level in boys and girls. And then if that comes low, you will send the child to a pediatric endocrinologist. So we know about delayed puberty. What about getting puberty faster than usual? So if a girl gets puberty before the age of 8, or boys getting the puberty before the age of 9, that's called precocious puberty. Okay, which means that their growth spurt will be earlier and their bone growth will be advanced. So in this patient, bone age will be more than chronological age. The true precocious puberty is 20 times more common in girls. So it's not uncommon for a 6-year, 7-year-old girl to have a puberty. But it's not very common for a boy. So for girls, usually we are not very concerned about precocious puberty. But for boys, we are concerned. So sometimes pituitary adenoma can cause precocious puberty. So if a boy is coming with precocious puberty, you would definitely order a MRI brain to rule out pituitary adenoma. But if it is a girl, then ideally we would not do it. Okay. Now, when we are talking about the growth and development, sometimes in the question you might be able to see this kind of growth chart. And then they can ask you that what do you actually think from this growth chart? So growth chart is a graphic presentation of children's gaining weight or height. So you can see it is for weight for age. So age is on the x-axis and weight is on the y-axis, right? And you can see this is 1 year. So it means 1 month, 2 month, 3 month, 4 month. And then there is 2 kilo, 3 kilo like this. So what you see in here is percentile. So this is the 3rd percentile and this is the 97th percentile. Any children whose weight is in between 3rd to 97th percentile, that's normal. Okay? If the children growth chart shows that it is below 3rd percentile, like over here, that's called failure to thrive. And that is something which is abnormal. Anyone's above this 97th percentile, that means obesity. That's also abnormal. Okay? Now, for this child, what will you say? You can see that everything is normal, right? It's between 3rd to 97, so it is normal. But there are a few other things which I would like you to know. That a child coming to the practice with the parents and saying that over the last 1 to 2 months, child is not gaining weight. And you checked it and you found that child at 10 months, child's weight was on 85th percentile. And then in 1 month time, so at 11 months, it is now at 15th percentile. We say that if child's weight dropped by more than equal to 2 percentile, so from 85, it dropped up to 15. So there is one line, sorry, this is one line and this is 2 line, right? So more than equal to 2 line, if within a very short time there is a sudden drop like this, that is also pathognomic or pathological. Even though it is within the normal percentile, but because of this rapid decline, there must be something going on with the child. So then you will be also concerned. Okay, so only time you will be concerned if the child weight is below this third percentile or if there is a sudden decline. Making sense for everyone? Okay. Next, pubertal gynecomastia. So this is a very common normal variant of male puberty. So when male puberty happens, sometimes you might be able to have a visible disc of breast tissue, and it might be, sometimes it can be like confused with excessive fat, especially if the child is overweight. But during the pubertal development, male boys can have a little bit of big breast, okay? Or they can have a bit of visible or palpable disc of breast tissue. That is gynecomastia, but there is no hormonal or medical treatment is needed for it. It is common and it will get better after pubertal development is over. So by the time the child becomes 18 or 19, this will be gone. So just reassure. Growing pains. So growing pains is also known as benign nocturnal limb pain. What happens is that during 3 to 12-year-old, the children is they're getting more and more height, they're gaining weight, so they're growing. So during this growing phase, children can have some non-specific bilateral lower limb pain. So usually bilateral and non-articular. So they will not come to you with a knee joint or ankle joint pain, but they will come to you maybe pain on the shin, calves, or thighs. So poorly localized, non-articular bilateral lower limb pain, which mainly happens in the night and gone in the morning, that's the time you would be thinking of growing pains. Okay, so usually occur late in the day or during night, and normal physical exam, no other abnormality, no pain in the next morning. Management, you just need to reassure the parents that it is growing pain and it will get better. Sometimes you can offer them some painkiller like paracetamol, that's it. And if the parents are doubtful and they want to know more, then yes, you can just do a ESR to rule out possibility of any inflammatory arthritis. But it is not must to do. Okay, so if you can reassure them and explain it, most of the parents will agree. Next, nocturnal enuresis. Very important for exam. So bed waiting is not uncommon, right? Everyone, like all of you know about bed waiting. So we say that up to 6 years, bed waiting is normal. After 6 years, it is not normal anymore. Children is supposed to have dry night and dry day, usually by the time of 6 years. There is a RCH guideline about this nocturnal enuresis. Please read that as well. If you see that a child is having this bed waiting even after 6 years, then the first test that you would do is to rule out any possibility of a urinary infection. So first thing is doing a urinary microscopy and culture to rule out possibility of an infection. Once you rule out infection, then the treatment will be mainly alarm therapy. So your first treatment is alarm therapy, which at least child needs to try for 12 weeks. And that's usually the first line treatment. If alarm therapy does not work, then there are some medication that can be tried, like desmopressin or imipramine. Okay, so let me have a go through from RCH about it so that you can understand. So typically treatment is not started before the age of 6 years. Okay. So you will go through the history a little bit. And go through the general advice. Bed alarm. So bed alarm is recommended in children from 6 to 7 years old. Okay. And it at least takes 12 weeks to work. Pharmacological treatment. So tricyclic medications are no longer recommended. But at the moment that we use, sometimes it's called minirin, which is desmopressin, melt or tablet. So when alarm therapy has failed or not suitable, then you can use the minirin. Minirin is very commonly used for short-term improvement or a rapid onset is required. Like child is going for a sleepover or child is going for a camping from school, then bed alarm is not going to work because it needs 3 months and you don't have 3 months in your hand. So you need something which can work rapidly. For that case, minirin or desmopressin is commonly used. So minirin can be used sublingually, can be used orally, but intranasal is no longer recommended because minirin can cause hyponatremia. Okay, so that's usually the treatment for nocturnal enuresis. Can it be familial? It can be, not always, but yes, it can be familial. What is alarm therapy? Ask me at the end of the class because I still have a lot of things to finish for pediatrics. If we have some time, then we will discuss something which is not very important and you can easily find out from here. Okay. Now, read Neonatal Skin Problem from John Motak, chapter 91. Now, it is not chapter 91 anymore because it was from the James 7th edition, but you open the 8th edition. Okay, so far we have discussed about this specific problem in children. Then if we go to the surgical problem, so if you open up the surgical problem in children, that's your chapter 85. So chapter 85, we will discuss a little bit from there, like plagiocephalus and all them. But I want you guys to have a look from here about some of the skin condition that can be present in pediatrics. So like infantile hemangioma, which is a strawberry nevi, then how the port wine stain look like. So have a look on the Google. Then this one we have discussed in our class. Okay, so in a specific problem of children, there are some common skin problem that it's not super important, but it's not a bad idea just to have a look on some of the pictures and know what it is. Like salmon patch, it looks like this in children. Nothing you need to do, it's just it will get better within 6 to 12 months. Infantile hemangioma, which is also known as strawberry hemangioma, it looks like this. Okay, and they usually involute and disappear by the age of 10. Active non-treatment is the rule. So usually no need of any treatment, but beta blockers can be given, which is like propranolol is useful. Then there is port wine stain. You can look at some milia, very commonly seen. Umbilical granuloma that comes in exam. So if you know what is umbilical granuloma looks like, it's a fleshy pink red growth around the umbilicus. Looks like this. Okay, so kind of a fleshy red growth around the umbilicus. So if you see this umbilical granuloma, what will you do? So you can use a silver nitrate stick or a copper sulfate crystal every few days until healing occurs. So that's the usual treatment, silver nitrate or copper sulfate crystal. Okay, so that's usually the one that you need to go through. The nappy rash, the dermatitis, we will discuss in our dermatology class. There is a condition called molluscum contagiosum, which you should also know. So it's kind of like this. So sometimes children can get this kind of like a pearly skin growth, and they will have kind of like a umbilicated appearance, like there is a dimple in the middle, right? So if you see this pearly growth on the skin like this, that's what we call as molluscum contagiosum. So it has a typical pink pearly appearance and a central punctum. Very common in children and spread by direct contact, sharing towels, etc. It can last for years. So nothing you actually need to do about it. So reassure the parents that it is fine, but advise not to share bath, not to share pool or any common baths, because using the shower or using the common pool or baths, it can spread to other children. But there is no need of excluding the children from school or playing together, because you can't exclude a child for a year, right? For this lesion. So it's not reasonable. Most common treatment is to leave the rash alone and wait for it to clear. If they don't want to wait, then sometimes you can just freeze this lesion. But if there is multiple molluscum contagiosum, freezing the lesion is not practical. So you just need to reassure the parents that it will get better. Okay? So that's about your neonatal skin problems. Few other conditions like surgical problem in children. So we have got plagiocephaly. So plagiocephaly is a condition in which there is asymmetry of the skull with a normal head circumference. So the skull looks like a tilted parallelogram, like this. So you can see that this is the asymmetry of the head shape. And this is one of the commonest abnormal head shape in a child. So It commonly happens in infants sleeping in one position, especially on their back. There is no impairment of cerebral development or intellectual development. So what is the management? So it involves initially changing the side to which the child usually faces. So main thing is that just like regularly changing the position of their sleeping is the initial treatment. If it doesn't work, then a cranial remodeling hamlet can be tried, best from 4 to 8 months. It's not a smallpox, Dr. Ahmad, but it is a kind of like a pox virus, but it's not a smallpox. Next, craniostenosis. So craniostenosis is a premature fusion of the suture of the cranium. So all of you know that the children, they have got this kind of suture in their skull, and at some point of their life, like between 12 to 18 months, those sutures and everything should be fused. But if it happens earlier than that, so if there is a premature fusion of their suture, then the head cannot get bigger, and it can cause abnormality of the head shape. Okay, so premature fusion of the suture of the head. Diagnosis can be confirmed by a radiography. This kind of condition needs to be referred to a pediatric craniofacial surgeon as soon as possible. Okay, because if, let's say that the skull and the head also grows as the child grows, right? So if the skull cannot grow, the brain also cannot grow. So it causes a lot of problem if there is a premature fusion of the suture. So in those situations, if there is a premature fusion and you no longer can feel the suture when you are feeling the skull, then you would refer the child to a pediatric craniofacial surgeon for repair. Not very important for exam, but plagiocephaly is important. Cleft lip and cleft palate. So only thing that you need to know from cleft lip, cleft palate is when is the ideal time for repair. So ideal age for repair of cleft lip is under 3 months, and ideal time for cleft palate is between 6 to 12 months. So that comes in exam. And there is a table in here that they have written what is the optimal time of surgery for some specific childhood surgical disorder. Like tongue tie, ideally within 3 to 4 months, cleft lip less than 3 months, cleft palate 6 to 12 months, undescended testis at least 6 to 12 months. Do not leave undescended testis more than 12 months. Then there is inguinal hernia, which is important for exam. Anytime if in infant you get inguinal hernia, idea is to surgically repair it ASAP. But for some reducible hernia, we follow 6/2 rule. What's that? 6/2 rule means if you have got a child between birth to 6 weeks and you have got an inguinal hernia, the surgery should happen within 2 days. Between 6 weeks to 6 months, surgery should occur within 2 weeks. And over 6 months, surgery should happen within 2 months. Okay? So that's also important for exam. So we follow this 6/2 rule depending on the age of the child. And if it is umbilical hernia, you can wait for up to 4 years. Now, there are some small topics that we still left with, like immunodeficiency in children. So immunodeficiency in children can be due to B cell deficiency, can be due to T cell deficiency, can be due to complement deficiency or neutrophil deficiency. So it's not super important for exam, but only thing you need to know is how they usually presents. So a patient or a child who has got B cell deficiency, the main problem is they get recurrent bacterial infection. So lots of sinusitis, lots of pneumonia. So that's how usually they present. And you check their IgA level. If IgA level is low, then you check their IgG and IgM. Most of the time, everything will be low. That's lack of immunoglobulin. Then T cell. T cell deficiency mainly comes with recurrent viral infection. So if a child getting recurrent viral infection, and with that also getting lots of fungal infections such as candidiasis, etc., and child having chronic diarrhea, failure to thrive, then you would think of T cell deficiency and you will check the lymphocyte. And you will find out that their lymphocyte count is quite low. For complement deficiency, it's not important for exam. They also get bacterial infection. And for this patient, you will have to do all the complement screening. Neutrophil deficiency comes in exam. So if someone has got lack of neutrophil, they get a lot of skin abscess. So if a child presenting with a lot of skin abscess, impetigo, cellulitis, then you can think of neutrophil deficiency. And then you do the neutrophil count and it will come as low. So B cell means bacterial infection, T cell means recurrent viral infection, and neutrophil deficiency comes with recurrent skin abscess. Okay, so that's how normally we would differentiate. Next, Duchenne muscular dystrophy or DMD. So Duchenne muscular dystrophy is it's kind of a X-linked recessive condition, which means it is a genetic condition. Because it is a X-linked recessive condition, the main diseased population will be the boys. So X-linked recessive, the main diseased population is the boys, and girls can be just a carrier. It's a condition caused by mutation of one of the gene, which is dystrophin, a protein found inside the muscle cell. So, and this protein is needed for muscle cell to become stronger. So, lack of this protein causes progressive proximal muscle weakness. That means their hip girdle or their hip and pelvis will be very weak. So, progressive proximal muscle weakness caused by lack of this protein is what we call as DMD. Because they have weakness in their pelvic muscle, these children cannot walk like other children. So there will be delayed motor milestone, and that's the time usually you would consider this condition. So children will have weakness in the hip and shoulder girdle. There will be delayed onset of walking, and they can have this kind of waddling gait, difficulty standing, climbing a stair. Because their proximal muscle is weak, their calf muscle can become hypertrophied because they will be putting more pressure on the calf muscle. Most of them will be in wheelchair by the age of 10 to 12, and the common cause of death is respiratory problem. There is a sign that we look for in these children called Gower sign. So I'll show you how that looks like. So this is how a child with DMD usually starts walking. So they first put their body pressure on the arms and on the leg, and then gradually they stand up like this. Okay, so that's what we call as Gower sign, which is a common finding in this case. So how to diagnose this? The initial investigation is serum creatinine kinase level. So CK level So it will be elevated. Once it is elevated, then you can do your investigation. So you can do a genetic test or a muscle biopsy. Okay. There is a guideline. If you go to GMT, Med Bullets, you can see in the investigation, first you will do creatinine kinase, and then you do the genetic analysis, which is gold standard. Even with genetic analysis, if it is negative, the last option is muscle biopsy. Okay, and treatment in this case is a steroid can be given as part of a treatment, but basically it is a condition which is not curable. Okay, so that's Duchenne muscular dystrophy. The main presentation is delayed motor milestone, and also they are having a progressive muscle weakness of their hip and shoulder girdle. Then there is a condition called SMA or spinal muscular atrophy. Very important for exam, SMA. So spinal muscular atrophy, it is also a autosomal recessive condition, and it is one of the leading genetic cause of infant death. So SMA has several types. The type 1 is usually the worst one, which comes during early infancy. And its main presentation is progressive muscle weakness and wasting. So what happens in that, the child will have progressive muscle weakness, poor tone, so hypotonia and floppiness. So one of the commonest cause of floppy baby is SMA. Because of their muscle strength is very weak, they have difficulty with feeding, very feeble cry, weak swallowing, coughing, and breathing. But they have normal intelligence and sensory modality. So their sensation is fine. They are intelligent like any other child. And one of the important thing is that these children, every muscle will be affected except their facial muscle. So sometimes in the exam, they give a clue that you have got a child who is having feeding difficulty, very floppy in nature, but child smile when you look at the child. So smiling needs facial muscle, right? So if there is a smile, which means facial muscle is working, so it could be a case of SMA. Diagnosis is by DNA screening, which means genetic testing. There is no treatment available. Another cause of floppy baby is Prader-Willi syndrome. Very commonly comes in exam. So it is a condition which has a very typical way of presentation. So initially, child will be hypotonic with weak suction and failure to thrive. So before onset of solid, so initially in the first 4 to 5 months when the child is just having breastfeeding, child will be very floppy, hypotonic, and muscle weakness. But once you start giving them solid food, they will develop a voracious appetite, causing morbid obesity. So they will become, so from hypotonia and failure to thrive, they will start to be very obese. And at around 3 years, they usually manifest. So neonatal hypotonia, failure to thrive, and later on becomes very obese, then it can be a Prader-Willi syndrome. These patients can have intellectual disability and some other abnormal facial structure. Okay, this William and Noonan syndrome is not important for exam. And the last thing is, if you open up this last page, there is some immunization guideline in here, which is not coming up. So I want you guys to know about the National Immunization Program for Children in Australia. So this is where you will be able to see the childhood immunization schedule. So you don't need to memorize this, but have some basic idea that at birth we give hepatitis B, then at 2 months we give this all the DTP and everything, 4 months, 6 months, at 12 months, 18 months, and 4 years. So have a baseline idea that what are the vaccine that we give and at which age. Okay, so that's important. All right, so that brings us to the finishing of pediatrics. It's a lot, right? I know it was a lot, and I could not answer few of your questions because it's really, really a lot of things to discuss. Still, we could not finish asthma, but asthma I will finish in the respiratory system. So when we discuss the adult respiratory system, we will discuss the asthma as well. Okay, no worries. So there is a lot to learn from pediatrics, as you can already understand, but nothing to be concerned because now you know the important topics. Now you know what to read. All you need to do is read. Okay? And it's not really hard as long as you can finish the topic that we have discussed. Okay? It's fun. Once you get the grab of it, it is really fun and easy. But initially, because there is a lot of topics which many of you never even heard of or never even read, it's here. So you might feel a little bit confused, concerned, and maybe a bit overwhelmed. But there is nothing like that. It will get better. High arched palate, you'll need to have a look on the Google about how it looks like. Okay, Dr. Bilal. But high arched palate is a feature of Marfan syndrome. But how it looked like, you have to have a look, like what exactly it means. It's kind of a visual understanding. Dr. Amar, are you a clinical student? This is the MCQ class. Why are you asking for role plays? Will we do urotherapy first or directly alarm? Alarm therapy is the ideal. Okay, that's according to RCH. They are talking about alarm therapy. Urotherapy is just about like training. So it's about toilet training. So which most of the time parents will do anyway. But as part of main treatment, alarm therapy is the ideal. Yeah, the cardiac mock is only on the website. So we don't take classes for mock exams. So whenever you will see the mock exam on our schedule, as you can see on the side bracket that there is no class. So you can appear the cardiac mock or any mock at any time. It is going to be there as long as you pass the exam. So there is no nothing like that you have to appear tomorrow. But if ideally we say that by this time you should be able to finish cardiology, should be able to appear the cardiac mock. But it's not mandatory for anyone to appear tomorrow. Okay? And you can appear at any time that you like. And the portal will give you the answer, portal will give you the mark and everything. And Dr. Nahid, the 6/2 rule is for inguinal hernia. So we say that if a child having inguinal hernia, then we follow this. So birth to so normally what we say in these children that if you have got a child who has got an inguinal hernia, like even if it is reducible, it has to be you have to go for surgery within as soon as possible. But there is a rule that we follow, like between birth to 6 weeks, ideally surgery should happen within 2 days. Between 6 weeks to 6-month-old child, surgery should happen within 2 weeks. And after 6-month-old child, surgery should happen within 2 months. So it's about age group when they are getting the hernia, and depending on the age, the maximum time that you can wait is like that. So 2 days, 2 weeks, or 2 months. Do we have class tomorrow? What's the schedule says? Guys, there is a schedule. Why you are asking this question? In 17. There is no class tomorrow, as we already said. It's just a mock test which you can appear anytime. Pediatric question solve will be the next class, so on 19th. The lecture is enough. As you can see that there is a lot that we have discussed, so it's enough for your pediatric preparation. If you can finish this much, it's okay. All right, everyone, we will finish it here tonight. Thank you all. Have a good night. Take care.